The following podcast is part of a certified educational activity titled Diagnose Early, Communicate Clearly, Optimizing Alzheimer's Outcomes in Primary Care. Access the entire activity and complete the post-test at peerview.com/DPF860. Downloadable slides and practice aids are also available.
Welcome to our program entitled Diagnose Early, Communicate Early, Optimizing Alzheimer's Outcomes in Primary Care. My name is Dr. Chuck Vega. I'm a clinical professor of family medicine here at the University of California, Irvine, where I'm also an assistant dean, and I'm really excited to be joined by an expert in this field. Dr. Turner, would you mind introducing yourself?
Hello, thank you, Chuck. I'm Scott Turner. I'm the director of the Memory Disorders Program and professor in the Department of Neurology at Georgetown University in Washington, D.C.
Thank you, Dr. Turner, for being here, and thanks to everybody for joining us today. This is a really important discussion to have, which I've certainly seen in the graying of our population. In my primary care practice, more and more folks diagnosed with cognitive impairment, but it's so important to identify them. And so that's one of the things we're going to talk about today is talk about strategies to identify older adults who are at risk of cognitive impairment and who have the incipient stages of Alzheimer's disease. And we will give you some skills so you can actually have an empathic conversation that many times not just involves the patient, but their care partners as well. And finally, we'll talk about shared decision making when it comes to breaking that news and then thinking about treatment, because we have some new and exciting treatments which are really disease modifying for Alzheimer's disease, something that's really we've been waiting for a long time. So let's talk about being in the primary care clinic and identifying cognitive impairment. It's a real challenge. It is very, very important, yet we know that only 8 to 15% of folks with mild cognitive impairment receive a diagnosis of MCI. In fact, a lot of those adults with MCI think that's a normal part of aging, to have memory lapses, to have repetitive speech, to have difficulty with complex instructions, when actually those are all pathological findings. And that's one thing we really want to be there in primary care to try to afford our patients, because the sooner we make a diagnosis, the sooner we can work on reversible causes of cognitive impairment, some of which we are engendering ourselves because we're giving medications maybe that can hurt cognitive function. We also want to really start lifestyle changes for patients to maximize their physical and their cognitive health. And then now we do have the opportunity to give more effective treatments for Alzheimer's disease in its early stages in mild cognitive impairment and mild Alzheimer's disease that really can be disease modifying. These monoclonal antibodies are pretty amazing. And Scott's going to go into how to apply those and the evidence for their efficacy in a bit here. The problem we have, as you all in primary care know, is that the average number of issues we have in a typical primary care visit is 7, and you might have a 15-minute visit or a 20-minute visit to get to those 7 problems. It's really busy, and patients feel that busyness too. They may come in with an agenda. If their ankle pain or their headache isn't addressed, they're not going to really listen to you when you start asking questions about cognitive impairment. I think there's also a bit of a sense of nihilism around the management of Alzheimer's disease. Well, we don't have any good treatment, so why should I even ask? And actually, that's what we're going to spend the last half of this discussion on. Is we do have some more effective treatments now, and so I think it's really worth being hopeful about. I also think it's important to think of patients' quality of life, the ability to make plans, to do the things that are important to them, and I think that is a critical part of being in primary care. I understand the patient's North Star and what they want to do. Maybe it's the vacation they always wanted to take, or that estranged friend or relative they haven't talked to in years. Once they get the diagnosis of early Alzheimer's disease, it's really important to have those conversations, and maybe that's the time you want to take those things and have those important life goals completed. But as we know, patients may be feeling some stigma and shame around their cognitive impairment, so there may be some denial. There's also a lack of awareness, as I mentioned earlier, regarding particularly those more mild forms of disease, whether it's pathological or not. And sometimes, unfortunately, families can try to hide and reinforce that as well. Because there are a lot of things we can do early when it comes to cognitive impairment. So the list is pretty long. So we want to control chronic disease factors. We certainly want to take a hard look at that medication list because that's one of the that's I go for low hanging fruit and what's easy. That's one of the easier things to do. Oftentimes is change some medications or discontinue certain medications, which could be interfering with cognitive function. We'll talk about the laboratory workup. We might find something a metabolic issue, anemia that could be contributing. The number one thing that I find that really makes a difference with our older adults when it comes to cognitive impairment, in terms of things that can reverse to improve that cognitive impairment, is hearing loss. So that many times folks don't want to wear their hearing aids, they don't do it, and when you can't hear well, it's harder to function, it's harder to communicate. It affects some of those important cognitive processes. Better hearing aids many times can make a difference, and that difference can be notable in a week. Some of these other ones are a little bit harder to get to. Now, there is from the Alzheimer's Association a new algorithm. This is they put out guidelines for primary care. It's intimidating. It seems like a lot because you want to establish goals. You want to have empathic and effective communication. You have to get a good set of symptoms, both from the patient and if a care partner is available from that person as well. And don't just think about memory, think about other cognitive domains as well, like executive function. Maybe their memory might be okay, but other domains might be affected. It's really important to know their history of cognitive function before there's this question of impairment. And I think that's one role we really should embrace in primary care because oftentimes we have long-term relationships with patients. Again, looking at their med lists, looking at other factors that may be impairing cognitive function, and then doing an exam. Everyone with suspected cognitive impairment deserves a neurological exam. If they have a focal deficit, that's going to move you away from Alzheimer's disease, certainly as a diagnosis. And then getting some idea more objectively, doing a screening test for cognitive function with anybody with a memory complaint or another cognitive complaint is really quite important. Um, then you talk about those results and decide on maybe we need further testing. Maybe this test the screening is negative and there's something else going on like a mood disorder, which is pretty common. The question is, can you do all this in 15 or 20 minutes? Possibly. I've found that, my practically speaking, and this is just my example, when patients don't come in with blood pressure out of control, with headache and vision changes, as my shoulder hurts, and it's time for I have questions about vaccinations. No, I'm not going to be able to get this all done one visit. If I have a fairly linear approach though, and I can get through all these issues, I can do it in 20 minutes and then make some positive next steps. And remember, when you can't get to it because you have other intervening issues, which are so important and you have to address them, you can, I always make a note, hey, we still have to do a cognitive screen. So let's get that done either via telehealth, and sometimes you can do like for reporters, you can have the those folks actually give their information offline and fill out an Alzheimer's disease 8 questionnaire when you're not seeing the patient, outside clinic time, and address it at your next visit. So you always have continuity to help you out because we should be on the lookout. We have to be good sentinels in primary care. And so, anyone with a memory complaint, if they're middle aged or older, generally I will give them a screener. We'll talk about those in a minute. But also, we might notice, and we have a case coming up that I think will highlight the fact that you could be the person who identifies a cognitive impairment because having 3 or 4 or 10 chronic illnesses is not only a full time job, it's cognitively complex to get to lab, to get to specialists, to get to ancillary studies, to take all those medications and treatments. And when you see a significant step up in somebody, particularly when they were hearing before and there's nothing else going on, they didn't lose their insurance. Boy, a lot of times I found multiple cases of cognitive impairment in my practice just by thinking. I think putting a little more thoughtful approach into the why of why is this patient suddenly having a hard time managing some of these issues. This slide really, I think, encapsulates a lot of what I just said. Definitely pay attention to health habits as well, particularly alcohol consumption can be really tough in folks who are older. And then I'm going to do a basic lab workup that's described here. Generally speaking, it's something that's readily available. I don't generally order screening for syphilis unless there's a compelling indication. Same thing with HIV. Many patients are screened automatically, and they already have a negative screen on file. But yeah, a limited laboratory workup is appropriate for these patients. A good physical exam, and then we get to choose between a variety of screening instruments. So here come all the acronyms. I don't know, Scott, maybe you want to share some insights. I have some favorites here, but what do you think is a good one to choose for a busy primary care provider?
Well, here in the neurology clinic, we primarily focus on the MMSE and the MoCA and the slums. And it would be great if primary care would also do these tests, but I totally understand that there's limited amount of time and these do take maybe 5, 10 minutes, sometimes 15 minutes to complete. And so there are a set of quick screening tests that have been established. And these are tests such as the 88 and the minicog that are sort of more designed for primary care providers because they take a lot less time, maybe less than 5 minutes to complete. So these, if you're not familiar with using these tests, these are all available at the Alzheimer's Association website. They're downloadable. They have cutoff scores and explanations about what's a concerning score, et cetera. So for primary care, at least do 88 or minicog sort of screening tests. Some are targeted at the patient, some are targeted at the caregiver. If you really want to, go full blast, then MMSC, slums, or MoCA is what we usually do in our clinic. And the MoCA is a little better than the MMSC, but the MMSC is still done a lot because all of our clinical trials have cutoff scores for the MMSC. So those would be my recommendations.
Well, it's very funny because guess what I use? I use the mini cog, especially when I have someone who does not have the significant risk factors for dementia, primarily age. It's a 48-year-old who's having memory troubles, but they're also having maybe some poor sleep and some low mood. As almost a means of reassurance, I'll give the mini cog because it does take only a couple minutes to administer. The 88 is also great, as I mentioned earlier. So that's for care partners, someone who knows the patient well and can give feedback, but I generally go with the mocha in a lot of cases. And that one, I often will schedule a separate visit because it does require a certain methodology. And I really want to watch my patient taking the exam. One thing with all of these, with all cognitive testing, the challenge is that most of my patients have a very low educational attainment. They're not used to taking tests, and it's been 50 years plus since they took a test. And so I watch how they take a test. Sometimes it's just the instructions that are really confusing for patients. So I try to help them where I can, but also you have to. I grade on a bit of a curve based on how when I watch them take the test, they're able to adjust those questions. One thing we also really need to do in primary care, when that suspicion is confirmed, we have a positive screener, initiate the lab workup, and also order an MRI of the brain. We need a baseline MRI. Everybody deserves at least one when it comes to cognitive impairment. And now we have a lot of opportunity to identify Alzheimer's disease using different markers. PET scanning can be a great adjunctive tool that provides more objective evidence. There are blood based markers as well that focus on amyloid in the bloodstream, among other pathological findings in Alzheimer's disease. So these are now starting to move into practice, and so it's something that your practice, it's newer for most of us, certainly. So we want to get used to them. Patients may be asking for them, and so this is something we will continue to incorporate over time. But I think it's important to think about the application of particularly blood-based testing because that moves it more into the primary care area. PET scanning can be very effective as well, but may be hard for us to get covered. And so now we're looking at, I think, really putting it together in a more holistic approach to the assessment of patient that definitely includes a good history, a good physical, some of these initial laboratory studies, getting at least an MRI of the brain, thinking about the application of blood-based biomarkers, and then also thinking if all of the screening is coming back positive, and we are starting to look very much like a diagnosis of Alzheimer's disease. Thinking about APOE genetic testing, and I'll save why for Scott's presentation, but it does have an important role in the prognosis when we think about the application of monoclonal antibodies. So let's try to put this together with a model and a framework that can work with for us in primary care to actually have these discussions. So This is the spikes protocol. So we want to set up the interview, know what the patient's coming from, assess their perceptions. Honestly, a lot of my patients, when I say, "Oh, I think that all the signs are pointing here to Alzheimer's disease," kind of moving forward to the conclusion, they'll ask me, "What is that? I don't know what that is," and so it's kind of surprising, but now I've gotten so used to it, it's not surprising to me at all. So we really want to understand where patients' perception is and what their understanding is, because that's going to change the way you talk. And I will ask, is it okay if we talk about your memory? And is it okay if we talk about cognitive function? Usually I say memory because a lot of people don't know what cognitive function is. And then I'm going to impart information. That's the K. We're certainly going to talk about, go slow, speak with empathy, speak with understanding, addressing the patient first. Maybe if they have a care partner in the room, they can also be addressed, but always the patient first. And then we come up with a plan together after shared decision making. So we are going to try to put some of those things together with a case for you now. So a 68-year-old woman, Edna, she has hypertension, hyperlipidemia, obesity, sensorineural hearing loss. She has osteoarthritis in the knees, glaucoma, and an overactive bladder. Now, her main complaint today is her knees. She's trying to take care of her grandkids. She has a hard time keeping up with them because of the OA of the knees, which is a shame. And her blood pressure is elevated as well, 172/94. It was high last time as well. We increased her amlodipine at that time, yet that didn't seem to have any effect. The blood pressure is going the wrong way. But you also notice that her systolic blood pressure over the last 3 years was all less than 140. She didn't have this degree of hypertension previously. She has 7 medications prescribed. One includes an anticholinergic. Are you starting to pick up on some of the clues? There's little pearls here as we go through. But when you ask her about her medication, she says, "Oh, you're giving me too many drugs. I can't keep them straight." Whoa, ruh she missed her ophthalmology appointment last month. Was she always kind of on time? So we know her in that pre-morbid phase when she was maybe more functional. And boy, I see a lot of risk factors here. For one, she has, maybe the anticholinergic drug could be affecting her cognitive function. But I just see that there's definitely seems to be a step off here, but no previous history of cognitive impairment. She was a city administrator 3 years ago, so that's good. Um, Ed, Scott, what do you think about Edna's case at this point?
Well, there are some red flags here, such as, is she really compliant with her blood pressure medications?
Mhm.
And because her blood pressure is sort of high, she says she's having trouble keeping her drugs straight. She's missed an appointment. So definitely warrants cognitive screening, partly because of her age and also because of her risk factors as well, not just the red flags. But certainly begin with cognitive screening, and you can do the shorter tests or you can do the longer tests, and then follow up from there. If there's it's a sign of cognitive impairment, then do the blood test and the MRI scan, and then see what those results are, and then proceed perhaps to if there are significant declines, then consider referring to a specialty clinic.
Yeah, absolutely. So let's see what happens. So it turns out, get a little social history. She moved in with her daughter last year. She says she's slowing down. What does that mean? Is it physical? Is it cognitive? Is it both? But she gives you permission to speak with her daughter. So great. Now we've got that person who can inform the case. And daughter confirms mom is more forgetful, repeating the same stories. She got lost on her way to the park, and the grandkids had to help her. So I put her through a mini cog. She scored a 2. I also asked the daughter to fill out a form, which I emailed to her. It's 88, and it turned out to be a 5, which is positive. So suggests that she has cognitive impairment. And I agree. Now we are going to initiate that. We are going to have an empathic conversation with the patient. We're going to initiate that lab workup. We are going to do the MRI of the brain and a biomarker, and then move forward. I'd probably refer her at this point for further diagnosis. And so we do have the ability to show you a case where we see that type of effective and empathic communication. And so let's go to that case right now.
Yes, Dr. Jackson took the time to explain my diagnosis and answer all my questions and my wife's questions about how this diagnosis will impact my life and my family's life. She detailed what additional testing we could do to figure out the cause of my memory symptoms. And she explained that the potential treatment options may be available. Some of the things she said and did, I really appreciate. And she wanted to make sure I understood that it wasn't the end of life as I knew it. and that she would continue to support me as my family doctor. Then she asked me how my wife and I were feeling, because she knew that receiving this news was a lot to process. She also reassured me that MCI is not the same thing as dementia. And while many people with MCI develop dementia after a few years, other people show little change over time. Also, there are lifestyle changes that people can make that could slow down the progression of the disease. She explained that in my case, my brain scan showed an atrophy in certain areas of the brain that's commonly seen in people with Alzheimer's disease. But if we want to confirm that it's Alzheimer's, I'm going to need to get a biomarker test to prove that I have these abnormal proteins in my brain that cause Alzheimer's. While she was explaining everything to us, she stopped several times to ask if we understood what she had just said, or if we had questions, or wanted her to go over anything again. When we were done, she gave us some really helpful pamphlets with more information about MCI and a list of community resources and support groups.
With that, I'm going to turn it over now to Scott, and he's going to move more into the diagnosis and treatment, including the use of monoclonal antibodies for mild cognitive impairment and early Alzheimer's disease.
Thank you, Chuck. So now next module, we'll talk about making informed A beta amyloid treatment decisions together. So we now have two anti-amyloid monoclonal antibodies that were approved in 2023 and 2024. These are given in addition to the older oral drugs in the clinical trial. So they are a significant advance in that they are first disease-modifying therapies to be approved for Alzheimer's disease. They lower amyloid plaques substantially as measured by amyloid PET scan. In fact, many patients go from a positive amyloid PET scan to amyloid negative at the end of the clinical trial, the 12 to 18-month treatment period. Other Alzheimer biomarkers are also impacted, such as tau levels in spinal fluid and tau PET scans, as well as inflammation and possibly neurodegeneration. Removing the amyloid does have a clinical impact in slowing clinical, cognitive, and functional decline for the average patient when the amyloid plaques are lowered. And on average, you save about 5 to 7 months of expected decline compared to the placebo group over 18 months. Now, it's important to set expectations. Although some patients do say that they improve, in general, everyone does decline during the course of the study. It's just that those who received the treatment declined less than those who got the placebo. There are, of course, side effects, and one of the major concerning side effects is called ARIA, or amyloid-related imaging abnormalities. It's the most common adverse events associated with the anti-A beta amyloid monoclonal antibodies. Typically transient, asymptomatic, and resolve on their own, but in some cases, they have been serious and life-threatening, and in other cases may lead to either permanent or temporary discontinuation of the antibody treatment. So we have to talk about the risk factors and detect ARIA early in order to avoid more serious side effects. These are results of the phase 3 clinical trial of lecanemab, which was the first anti-amyloid antibody widely available for prescription use. And this is results from the phase 3 Clarity trial. On the left, we have the amyloid PET scan. And so you can see a significant decline in amyloid PET on the blue line compared to the level line in the orange in the placebo group. So no change really in the placebo group, a significant clearance or removal of amyloid by the anti-amyloid antibody treatment, which is given every 2 weeks. On the right, we have the clinical dementia rating scale, some of the boxes. So this is a scale that measures cognition and function. The orange line at the bottom is the placebo group. The blue line is the lecanemab treatment group. So you can see the significant less decline in the lecanemab treated group compared to the placebo. In fact, this was the primary outcome measure, and there was a 27% slowing by lecanemab at 18 months. So this was really our first disease-modifying therapy, and it was results such as this that led to the FDA approval of this antibody treatment. Similar results with the second antibody, which is called donanemab, and these are results from the phase 3 clinical trial, which was called the Trailblazer study. On the left, again, we have the amyloid PET scan. So you can see the clearance or removal of the amyloid by the two lower lines with donanemab treatment compared to the level line at the top, which is the placebo group. So basically no effect or maybe slight increase in amyloid burden in the placebo group compared to very rapid and significant clearance of amyloid PET as measured by a centiloid scale, which is roughly 0 to 100. On the right, again, we have a clinical outcome measure, the clinical dementia rating, some of the boxes. So on the top, we have the donanemab treated group. On the bottom, we have the placebo group. And at the end of the study at 76 weeks, there was a significant benefit of treatment compared to the placebo. Now, again, you can see everyone declines, but those who received the donanemab declined significantly less than those who got the placebo. And in fact, there was a 29% slowing by donanemab at the end of the study at 76 weeks. So both of these clinical trials had similar benefits of treatment, very rapid and significant clearance of amyloid by PET scan, resulting in positive clinical outcome measures, measuring cognition and function, and not just in the clinical dementia rating scale, but many other scales as well. One of the major side effects is ARIA, or amyloid-related imaging abnormalities, of which there are two types. One is ARIA-E, which is edema or effusion, and the other is ARIA-H, which is hemorrhage, which could be considered hemoglobin, which turns into hemosiderin. So you can see these side effects readily on MRI scans, so there's a lot of MRI monitoring which is required, one at baseline and then for regular intervals at the beginning of the anti-amyloid therapy. Now, most of the ARIA is asymptomatic and found only on MRI scan, but here on the left is a moderate ARIA-E patient showing the increased signal intensity on flare on the left. And on the right is an ARIA-H. So all of the black dots within the red circle are microhemorrhages. And we often see microhemorrhages or ARIA-H within regions of ARIA-E, and here's another example of that. This particular patient may or may not be symptomatic from their ARIA. If there are symptoms, it's often headache or worsening confusion. So certainly need clinical monitoring and MRI monitoring to look for this possible side effect. There have been a few cases of disability and death as a result of the ARIA. Interestingly, rates of ARIA are different for different ApoE genotypes. So we strongly recommend or sometimes mandate ApoE genotyping before starting the anti-amyloid therapies. You can see from this graph with both lecanemab and donanemab, there's an increased rate of ARIA-E and ARIA-H for every allele of ApoE4, roughly or approximately doubling the risk of ARIA-E and ARIA-H for every allele of ApoE4. So those with the highest risk are the ApoE4 homozygotes. For example, with lecanemab, the risk of ARIA-H with ApoE4 homozygotes is 38% and 50% in donanemab. This has led to some practitioners or prescribers not recommending the antibodies for the ApoE4 homozygotes. But we've adopted the policy of treating these individuals as long as they fully understand their risk of getting ARIA-E and ARIA-H based on their ApoE genotype. So it's important to select the right patients for the anti-amyloid antibody therapies. Inclusion criteria include a diagnosis of either mild cognitive impairment or mild dementia due to Alzheimer's disease. We have to confirm amyloid positivity in the brain, usually by amyloid PET scan, but less commonly by amyloid measures in cerebrospinal fluid, and also by blood-based biomarkers. Now, we haven't yet treated individuals with anti-amyloid antibodies based on a blood biomarker alone. We're using those as screens to determine who should go on to get the amyloid PET or the spinal tap to confirm amyloid positivity. They have to be in the mild stage, meaning an MMSE score of roughly 20 to 30 and a MoCA of greater than 18. We also highly recommend or mandate ApoE genotyping so we can have a more informed discussion of the risks of ARIA-E and ARIA-H. There are certain exclusions, patients who would not qualify for the antibodies, and these are people who could not get an MRI scan for some reason, either claustrophobia or some metal in their body. And the major risk factor for ARIA is amyloid angiopathy. So this is something that we can't see on MRI, but we can see the results of it. And the results of it are usually microhemorrhages. So if you have more than 4 microhemorrhages or more than one area of superficial siderosis, hemorrhage on the surface of the brain. This is considered significant amyloid angiopathy, and these patients would not qualify for the antibodies because the risk of ARIA is too high. Other exclusions are severe white matter changes of any macro hemorrhage or more than two lacunar infarcts or a single infarct more than 1 centimeter. Obviously, you'd want the patient to be medically stable, and we're not allowing the use of anticoagulants because of the risk of hemorrhage, based on the few fatalities that have occurred from ARIA-H and hemorrhage with the use of these antibodies in combination with an anticoagulant. So there are lots of topics for discussion with both the patient and the care partner. One is setting expectations. We have to tell them that this is not a cure, that the dementia will progress and advance. It would just progress and advance more slowly with the antibody treatments compared to a placebo group. And patients can stay in the milder stages for longer duration. We also talk about the risks of treatment, including the risk of ARIA-E and ARIA-H and symptoms to watch out for. As I mentioned, the most common symptoms of ARIA-E are headache, confusion, dizziness, visual changes. And we talk about a patient's individual risk profile based on their APOE genotype. There's also a significant time and effort commitment from both the patient and the care partner. They have to get an IV infusion. They have to go through all the tests to see if they qualify for the antibody, and they have to uh, agree to do the MRI monitoring to look for the ARIA and perhaps stop it in the earliest stages. Now, Medicare is covering the cost of the antibodies and the cost of the amyloid PET scans and cerebrospinal fluid tests, but there may be some copays and some other costs that would fall onto the patient and the care partner. Many other questions remaining, and there's controversial areas in this field, including should ApoE4 homozygous be treated? Should we allow anticoagulants or not? For now, we're erring on the side of safety and not allowing anticoagulants. But there are other questions, such as would we allow older or younger patients than those in the phase 3 clinical trials? When should we stop treatment? With donanemab, the treatment is stopped once the amyloid PET scan becomes negative. With lecanemab, treatment is continued indefinitely. And would they consider getting the antibody if there were a clinical research study that would be available to test a new compound? Now, we're starting to incorporate the antibodies into the inclusion-exclusion criteria for our clinical trials, but most of our clinical trials currently would not allow the use of the antibodies. So this is another question for discussion. Our patient um, had a normal MRI scanning, meaning atrophy and white matter changes, had a positive amyloid PET scan after a positive blood screening test, had a MMSE score in the mild stage and was diagnosed with mild cognitive impairment, had an ApoE genetic testing, which indicated no ApoE4 alleles, putting her at low risk. And so this individual eventually decided to participate in get the antibody treatment to lower amyloid burden and slow down the rate of cognitive decline. Now we'll hear again from our patient.
Yes, Dr. Jackson said that you wanted us to understand that it was completely up to me if I wanted to get that biomarker testing. I said that I wanted to learn about all of my options. She said she would give me a referral to a memory specialist who can order the biomarker testing to confirm that I have Alzheimer's disease. The specialist would be able to determine if I was eligible to receive one of the new Alzheimer treatments. The tests and treatments would be covered by Medicare. And she said that if I'm eligible for the treatments, the decision, of course, regarding whether or not to get treated would be up to me and my family. She also let me know that whether or not I decide to move forward with the treatments, with the new Alzheimer's drugs, she'd still be involved in my care. And we can also focus on improving some other health factors that I have more control over that might impact my disease progression. For example, I was recently diagnosed with high cholesterol, and if I decide to make changes to my diet and start taking meds to lower my cholesterol, it may improve the health of my brain.
So just some take-home messages. Perform cognitive, behavioral, and functional screening on all adults for symptoms of cognitive decline. If there's any indication either from the patient or the family or from your evaluation, then certainly start with the cognitive screening test. For patients with suspected neurodegenerative disease, do a more comprehensive diagnostic workup, such as the blood test and the MRI scan. Employ principles of shared decision making to engage the patient and the care partner with the informed discussion about the diagnosis, the clinical course, the risk and benefits of treatment with the anti-amyloid therapies, and the use of blood based biomarker testing to pre screen patients for eligibility for the new treatments. As mentioned, we're increasingly using these blood tests, not just in research, but in clinical care to decide who should go on to get the amyloid PET scan or the spinal tap to confirm eligibility for the anti-amyloid antibodies. So thank you for joining us today.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant by Eisai Inc. To access all materials for this activity, visit peerview.com/DPF860.